right, class. Our next topic for this unit is looking at post-traumatic stress disorder and how therapy would go about trying to treat that. So using the feedback you received from the bulimia charts, you're going to do something similar today with post-traumatic stress. So if you haven't done so already, I want you to go through and fill in the left half of the chart, listing all the different causes, the etiology of post-traumatic stress disorder, what are some biological elements, psycho elements, social elements that might play a role in this, and then go through and give me some of the symptoms. Again, you'll be listing the affective, the behavioral, the cognitive, and those somatic symptoms. So go through first and fill in that left half of your chart, and once you've done that, hit restart on this audio lecture, and then you'll go through and slowly work through adding information to the left side of your chart. All right, so one thing we could do is address the biomedical options. All right, we know from AP psychology that the most prevalent form of biomedical treatment is we would use medication. And so antidepressants work. They are as high rates of depression, comorbidity with post-traumatic stress, just like there is with bulimia. And so sometimes treating those depressive elements will help the post-traumatic symptoms be cured as well. And so antidepressants can be used. They're slower to kick in, especially if you're using SSRIs. And so it's a slow build-up process. But with this, it also affects the symptoms as the talk therapy will kick in and help you work through those depressive elements. What tends to be more common with most post-traumatic stress is we use anti-anxiety drugs, various forms of tranquilizers. And so we talked about this last year in AP psychology, but how anti-anxieties work is they are depressants. They slow down your central nervous system, your brain, and your spinal cord. And by slowing down those neural reactions, those neural communications, it helps lessen the autonomic responses of the body. So how they work usually is they'll be an agonist to GABA. GABA is your body's main inhibitory neurotransmitters. It stops the sending of signals. And so by having this drug that pretends it's GABA, it helps slow down the reactions and therefore gives your body kind of time to process what's happening without the autonomic fight or flight symptoms kicking in. They have an instantaneous effect, more so than our antidepressants, where they have to build up over a couple of days, a couple of weeks. And so they can be effective within the first time of using them. Sometimes they're used as spot treatments. So it's just, I have a panic attack and I can take a pill and that'll help calm me down instantaneously. Sometimes they're extended release, and so maybe it's something I take in the morning and it's a slow, steady release of these drugs to help keep me calm throughout the day. But because they're an instantaneous fix, without necessarily fixing any of the causes, there can be high rates of addiction. It's not treating the cause, which means I consistently need the drug. Since it gives a calming effect, not necessarily euphoria, but calm and content, there are cases of high addiction to these drugs. Now, for example, anti-anxieties tend to be near the top of the list for recreational drug use, where they're not used for their prescribed purposes. You have to be very careful with these anti-anxieties because they have a high reactivity with other drugs within the system. So, for example, if you take anti-anxieties and you're drinking alcohol, well, both of those are depressants, and so they will they'll kind of amplify the effect of both, and it'll shut down a lot of systems in your body, so it's dangerous. Also, what we find is that because it's not necessarily treating the causes, sometimes when you go off the drug, there's a high rate of relapse. And so post-traumatic stress sufferers that don't get at the root cause of the problem of what the trauma was and trying to go through the memories of that, it does put them at greater risk of relapsing to those problematic symptoms when they are when they go off the drug and try to, live their life normally, but I'm doing air quotes that you can't see. And so there is a risk of getting the symptoms back from that disorder. Right. Another newer approach is we could do biofeedback training. Right. With this, it's often used in conjunction with some form of talk therapy. But you hook your patient up to monitors, kind of what you see in that picture there, and it helps them see their heart rate, any respiration, perspiration on their skin as well, and then they talk through the traumatic event. Right? What they can do on the screen is see how their body is reacting. They see those stress responses, but also they're physically feeling it in that moment. So the idea is that they can get more control over their autonomic nervous system, help recognize what does their body feel like before they get to a panic attack. So maybe they can take conscious control over these automatic symptoms and help prevent the escalation towards a direct panic attack. If we were going to do a comparative study with biofeedback training compared to drug therapy, it's more costly and it takes a lot more time since it's relatively new. And by relatively new, I mean within the last 10, 15 years that we've been using it. There isn't as much studies on it, and so we don't know potential long-term effectiveness rather than just short-term elements. It takes a lot longer for you to recognize your body symptoms, and so if I want a quick fix, but the drug options are faster in this sense. Even the antidepressants, those will start to show neurochemical changes within your brain faster than maybe control groups within the biofeedback compared to our experimental groups in biofeedback. The experimental groups get there, but it takes a lot longer compared to just the medications alone. All right, so what I want you to do is think about these biomedical approaches and how could you use them to either fix a cause and or symptom of post-traumatic stress. So just like you did last time, explain a link between a specific cause or a specific symptom and how that treatment option could be used within a treatment plan. All right, what we could also do is focus on individual approaches, using that one-on-one talk therapy approach. So systematic desensitization, we talked about a lot last year in AP psychology. But for those who don't remember, you use those anxiety hierarchies. So our person here in the picture who's afraid of spiders, you start small with maybe thinking about a spider. And then you get used to having these relaxation techniques, get more comfortable. And then you might look at thinking about a spider goes to a picture of a spider. And then a picture of a spider goes to being in a room with a real spider. And then from being in a room with a real spider, maybe holding a spider. All right, so we use that a lot with phobia, but we could also use it with post-traumatic stress. All right, we need to teach them relaxation techniques to help them deal with maybe potential triggers within their environment, things that set off these flashback memories and these traumatic moments that they come back to. We know that there's high rates of comorbidity for agoraphobia with post-traumatic stress. Agoraphobia is that fear of being in a public space you can't escape, and so they tend to be reclusive and stay within their homes. Right, so what they do is with using this systematic desensitization for post-traumatic stress is you create that safe environment. You let them know that they're safe. Just remembering things doesn't mean that they're actually living through it again. Address the fact that anxiety will lower over time. It's not going to be a fix today or maybe this week or this month, but eventually we will get there. And recognize that these symptoms are under your control, that you can recognize and respond to them. And so there are things you can modify within your environment. We've been able to use post-traumatic stress with virtual reality therapy where they do similar things. Where you're exposed to traumatic images to help you kind of relive in those moments in a safe environment. So eventually the triggers will not be as disastrous, and they've been relatively effective. However, before it gets better, it can be a lot worse. Right? Having that forced focused on the trauma and the reliving, we find that a lot of patients drop out. And so some controlled studies, they report high rates of success, but they don't necessarily tabulate the dropout rate. They only look at the people who've stayed in it for a long period of time. And usually if you stay in it, it's because you have faith in the process. And so it might be more the placebo effect than necessarily the skills that they're learning in therapy. All right, what we also find is that early intervention can be very helpful. All right, traumatology is a field of clinical psychology where they look for areas that have experienced trauma and they try to get boots on the ground very quickly to have clinical therapists there to help individuals recover from this trauma. So individuals suffering from natural disasters, mass shootings, the book that we were going to read looked at the rise of traumatologists who went to Sri Lanka following years and years of this civil war, and then they experienced the effects of the tsunami. And so they realized that that community were at a greater risk of possibly developing post-traumatic stress, and so they wanted people there. The hope is that you show victims that they're not alone. They can start aiding in that transition from life before and after the trauma instantaneously, in the hopes that the symptoms of post-traumatic stress don't become entrenched and the disorder never actually manifests. However, the opposite could also be true. All right, maybe because you are there and told that you're at risk of this disorder, it actually makes you develop this disorder. Most communities are very resilient when they've undergone moments of trauma where they bond themselves together, come out and help each other out. And so that individual social networks tend to be more effective with preventing post-traumatic stress. And so the majority of people don't need clinical psychologists right away. It's only the few that are most at risk. But by giving everyone the same treatment, the same awareness, we do find a spike in the amount of people diagnosed with post-traumatic stress. One, maybe it's because we're now accurately identifying it and treating it right away. Or two, maybe it's we're putting these people at greater risk by focusing on the trauma so intensely that they develop it, or in another situation they wouldn't have gotten it. And so it's under emphasis on resiliency that most humans have, that traumatology might put individuals at greater risk by trying to be more helpful than necessarily is needed in that direct moment. All right, well, we could also try something known as testimonial therapy. We kind of talked about this in our interview unit, looking at the different ways of gaining stories and information while we interview subjects. And so that narrative interview style has actually been modified to help with a therapeutic technique. This is useful with individuals trying to come to terms with trauma that they've experienced individually. So, for example, it was used with Bosnian refugees following escaping the genocide within their countries, individual maybe victims of rape or things like that. They'd be able to go through with their therapist and they talk through what happened. It's not just getting the timeline of events and factors that all went into it, but also looking at their personal moments, trying to give meaning to it and what it represents for maybe their social network, what it means for their community. And so it helps them create that individual identity and connection to their cultural identity. So the study done with the Bosnian refugees, trying to come to terms with the fact that you were targeted for a specific trait that others in your community didn't have. And so by addressing the religious overtones of these attacks that experienced, and knowing it was your neighbors, it was people that you've gone to school with, your coworkers, right? What does this mean? And trying to reconcile your identity before the trauma to your identity after it. All right, trying to work towards forgiveness and acceptance of yourself, trying to recognize the members of the family and the community that are still there for you. Right, so they use this testimonial psychotherapy to help people make sense of the trauma and then make sense of how their life can move forward beyond it. And so it helps because it allows for inconsistencies to kind of be cleared up and give sense to it. But again, it's very intensive, one-on-one. It takes multiple sessions to go through this. And so it might not be available for everybody because it is kind of costly with the amount of time you have to dedicate to one-on-one therapy. All right, so thinking about all those individual approaches, go back to your charts and explain how could you use individual therapies to either help the causes and or the symptoms of post-traumatic stress. And so add that to the right side of your chart. All right, and then the last ones we're going to look at is the group approaches. How could we do group therapy to help individuals? We know that there's a lot of groups dedicated towards collective trauma moments following the events of 9/11. There were a lot of post-traumatic stress groups specifically within New York City. Vietnam war veterans in general, they have post-traumatic stress groups dedicated towards them. And so what Friedman and Schnur tried to do was look at how effective is this focusing on the past rather than just focusing on living your life in the moment. So they did a study where they had war veterans, some diagnosed with PTSD, some of them not, and they divided them into two groups. Right? One control group just focused on their current life issues. Still a group situation, still getting support, and so the traditional therapy processes. The experimental group, they did psychoeducational groups, understanding your internal angers and what's the best way of expressing them. Working through your trauma and looking at the events that triggered the situation, and then trying to educate them on the best way of coping with those stressors, coping with those emotional moments, and then moving beyond. And so it was very trauma focused compared to maybe just day-to-day life focus like the control group had. Right? If we compared the two groups, my experimental group had a much higher dropout rate. But those that stayed in the experimental group had a greater level of success compared to those people who stayed within the control group situations. And so, yes, it's effective, right? But again, those moments of trauma, having such intense focus on it, it can worsen the symptoms, worsen the effects. And so there is a high dropout rate, a high relapse rate, right? If you can have some accountability within your group therapy, it does help with that. But we do find that the trauma educational focused, while very helpful and effective, can be very alienating in the short term. All right, now another group approach is we could try to apply the ideas of cognitive behavioral therapy in a group setting to help individuals overcome their trauma. This is helpful because it can have people from different trauma experiences be able to still come together and try and see that they're not alone, see that other people have been through similar experiences, and then talk about behavioral changes that they've tried and see how that helps them. All right? As you're sharing things with people in similar situations, it adds to your self-efficacy, greater confidence in yourself, giving new coping strategies, talking about your interpretations and hearing other people say that it's not unreasonable, maybe irrational, but not unreasonable to feel and think that way. And so it helps bond the group together. And so what we find is that group comparison, if you look at how you're progressing compared to the rest of the group, that can be defeatist, right? But if you look at the group as the whole, usually the group gets better over time. There are few individuals that are highly successful, few individuals that are not as successful, but if we average out all of them, the group tends to improve, and as long as you don't focus on how you might be lagging behind others, it will be successful. But if you do focus on your comparison to others and how quickly they're succeeding compared to you, there is a high rate of relapsing. And so interview studies have showed that if you can minimize the group comparison element, as easy as that is for the group leader to maybe do, everyone does tend to benefit from that combined cognitive behavioral approach. All right, last time, go through, add in your treatment to the causes, your treatment to the symptoms using the group therapy techniques. I heard from your request that you didn't like that the closing reflection was in the slides, so I've added this to the instructions instead. So once you've finished with this, you are done for the day and just submit your worksheet.